I'm Audrey Thurm. I'm a psychologist at the National Institute of Mental Health in the intramural program in Maryland. And we are one of the sites for the Rare Disease Network that we've been talking about. That's the natural history study, the longitudinal study. And there's the logo that I put on so we can all recognize it. And today I'm going to talk about talking. So I think that the only thing I can take credit for is the theme of these titles, because mine is Let's Talk About More Than Just Talking, Language, Communication, and Social Behavior in Phelan-McDermid Syndrome. So I'm going to start, and it certainly is a perfect topic to talk about in relation to cognition or after cognition, because these things are very intricately related. But I'm going to talk about three different aspects. Communication is actually the broad topic, right? And just defining that as the exchange of information. So any exchange of information, either using language, verbal means, or nonverbal means, things like eye contact, gestures, when there isn't speech or language. And then I'm going to talk very specifically about language, which includes speech development as well as written language. And within all of these, there's aspects that are receptive, communication, which would be requesting, asking for things, and then sharing enjoyment or having reciprocal exchanges. So those are the kind of definitions, layouts of what we're talking about. So the first topic is language, and so what does the language impairment in Phelan-McDermid syndrome look like? And so the first thing I want to say is, from everyone in this room, and especially newcomers, I want to talk about the fact that it is variable. So generalities here may definitely not apply to your child. But in general, we can use the term minimally verbal to talk about the group of individuals in general with Phelan-McDermid syndrome. And this is a term that's been used more recently in the autism literature to sort of replace the term nonverbal, because it can include individuals with some words, but who are considered to have very minimal speech output by the age of 5. And that term really is now in the literature to talk about those group of individuals within autism, which used to be considered about 50% of those with autism, and now is thought to be as low as 25% in general with autism. But as you'll see from these numbers, it's at least 75% of what we know about in the Phelan-McDermid group. So these are from previous reports, the same reports that we saw presented already, and I just wanted to show not just the delayed or absent speech, but it has to be put in the context of the developmental delays which lead to the intellectual disability, as well as in the autism behaviors, because all of these things affect each other. Obviously, if there are general cognitive deficits, it makes language learning a lot harder, and clearly we know that symptoms of autism make language learning harder, because when that basic social reciprocity isn't there, the motivation for interchange, especially when it's for the real social pieces, not just requesting, is limited. But we can see from studies of various sizes that developmental delay was pretty much across the board in these different studies, as we've already heard about, and that the delayed speech was very pervasive, almost 100% in all these studies. Again, these are earlier studies of cohorts diagnosed earlier, before more individuals are getting genetic testing, and we certainly may see these numbers change, and we know we are from even just in the last year of who's coming into the natural history study of some, especially the younger children that we're seeing. And then again, just looking at the autistic behaviors, and these are defined very differently in the different studies. We have to keep that in mind. We see all kinds of ranges from 26% all the way into the 90% of of levels of autistic behavior. And we can talk about how there's different ways that you can measure autistic behavior that will change those numbers dramatically. So again, this is from a large study, one of the largest studies that includes surveys of parent report of speech development as well as other behaviors. So again, you can see that these are into the context and also related to deletion size, which I won't get into too much. But here you can see that it was about 78% of those were either had no words or less than 40 words, so considered minimally verbal, of individuals with Phelan-McDermid syndrome. And again, showing some of the other symptoms as well. And then, excitingly, because of all your work, I think this is, well, not the only registry data shown, but we do want to show that in this case, the numbers were almost identical based on, this was 383 respondents to the registry data, which showed pretty much the same in terms of 76% of individuals that were older than 2 years when language typically develops were shown to not communicate with words. So that was output, and then the registry also asked questions about receptive language or understanding, and this is what was shown as results. And this is, I think, a lot harder to sometimes interpret in a question and needs more detail way of asking. But here it showed that 40% could understand and follow one-step directions, 25% two-step directions, and then a variety of other answers. So again, from the same, one of the same studies that included more than 30 individuals with Phelan-McDermid syndrome, this study actually did standardized tests of language as well as cognition and fine motor and gross motor skills, and kind of putting it into context of an age equivalent, because as Dr. Soria talked about, standard scores are very hard to get in individuals over 5 who are using certain tests like the Mullen scales, which a lot of you may have heard of, where that was used as one of the tests here. We can see that from the Mullen, which is a test of cognition, including language, as well as the Vineland, which is a test of adaptive behavior, what we were just hearing about as sort of the functional outcomes. We see here that receptive language was, on average, again, just an average from this group, found to be around at the 12-month level, which is consistent with understanding one-step directions for most individuals. And then expressive language was lower than that, again, averaging somewhere between 8 and 9 months in this cohort. So just putting this into context of the age equivalent of what you would see in those ages. And again, thinking about why these things are the case, we see that the motor skills are also, they're above the language skills, but they're also quite impaired. And we think that between cognitive skills and motor skills, that's some of the driving force prohibiting the language. So when we say that there's a relative weakness in language in Phelan-McDermid syndrome, it's not just on its own or in isolation. It is because of these other factors. So that's all I'm going to say about speech. So we sort of know the lay of the land of where speech is in this group, and we absolutely need to have another session talking about ways to increase speech development using terms like apraxia, oral motor output, and lots of different ways that we can work on treatment for speech itself. But I'm going to focus on the broader communication for a little bit, because I think that area is talked a little bit less about, and there are ways that we can intervene with alternative ways of communicating. So I know in previous years there have been talks on augmentative and alternative communication. So what I'm going to talk about here is sort of the basis in how we measure and think about the foundation of communication to think about alternate and augmentative ways to communicate. So as you can see here, these are just some of the ways that a lot of you probably have heard about. So PECs, using cards with pictures as a way to communicate, and then now a lot more ways to communicate using devices. And I purposely brought mine because we all have them nearby us all the time, and so they can be very, very helpful in helping us think about different ways to communicate, especially using visual input. So communication is harder to test than speech language. Some of you have been involved in the studies where we can just check off words that we think the child understands, and obviously the output we can test ourselves easily with standardized tests. Communication is a little bit harder, and some would argue that you really need to get to know the individual to know what they're motivated for, to really be able to assess how they communicate, because we all are not interested in the same things, even the same foods or same highly motivating reinforcers. So we need to use the best methods, which are highly individualized. But the two ways that we get at our understanding right now of communication are either through, again, functional assessment based on asking parents or caregivers about both understanding and expression. Again, we might not see this in our session in our lab or clinic, so we need to ask about what's happening at home. But then we also can use measures that are somewhat standardized, but they're a little bit more observational, so they take a little bit more time. So just to think, because we all know what we mean by speech development and language, but for broader other communication methods, I just wanted to spend a little bit of time, because I think there are ways that individuals with Phelan-McDermid syndrome are either communicating or trying to communicate that may be a lot more subtle, things that we do see typically in the infancy range, which is the age equivalence that we showed, that we just don't think about or pick up on as much in older individuals who may still be trying to communicate this ways. And for those who have been working with families, we hear this all the time, and we all see that families are saying, you know, I think he's hungry now, I think he needs this, I think he needs that, and without knowing the child and really, really getting to spend time thinking about these subtle different changes in behavior, other people will not pick up on the ways that are being communicated. So just, we don't have a great sort of milestone achievements for communication as we do with speech and other behaviors, but this is sort of a really rough rubric for that, where the earliest levels are just body movements. So it just may be changing your orientation slightly, and it may be really simple gestures, reaching out, early sounds. So even if an individual is only making a few sounds, those sounds might have some subtle differences between them that may be important and meaningful to that person. Facial expressions, again, they may not be typical facial expressions, and they may be more subtle. And then visual, just looking at things. And we now have technology that can help us use that to communicate. And then higher level are more conventional gestures, waving, things like that. Concrete symbols, so being able to use pictures, things like PECs, which again is in this higher level, and then abstract symbols, letters, words, and language. So what I want to just point out here is, I'm sure half of you can't see this back there, is just that now there are some measures being developed, and this one at University of Kansas, where some of our speakers are from, is a measure that's being developed specifically for individuals that are not just in infancy, but older individuals who are in this sort of less than symbolic or intentional phase of communication development, either just in the intentional non-symbolic phase or even in the pre-intentional, which means that it may not be obvious the way that they're communicating, but it's there. And so this is not to memorize, but just to point out a few examples here of things like just alerting, just moving a little bit may be a way of someone showing that they're communicating, or just, again, orienting or scanning between the object and the person back and forth may be their way of saying, I want this, and then getting higher level skills into what we call a triadic gaze, where you're looking at the person and then the object and then back to the person, which we start to talk about as joint attention as a way of communicating. But those are already higher levels. So just that we can break this up into these sort of lower level, more basic single behavior ways of communicating. And there is a hierarchy that we can be, meaning speech therapists and people working with individuals who are not verbal can be trying to work on the next skill and sort of a curriculum approach. So, and this is based on what we know from typical gesture development in infancy, and we're starting to get data on this, and we still don't really have, as I said, a good sort of communication milestone achievement scale, but this is just showing you that there is some hierarchy here of certainly reaching and then pushing away, using eye contact, and then integrating multiple behaviors. So to sum up, that we do know that individuals with Phelan-McDermid syndrome need alternative communication strategies. Again, continuing to work on speech development, but having other ways of communicating as well. And right now, we know there is a tremendous amount of technology out there, and it's growing and growing and growing. The limiting factor from talking to families and working with families is not so much the technology. We're seeing lots of families being actually offered iPads, other devices to work, but it's that training piece, and it's especially the individualized training for families for where the child is at developmentally that seems to be the stopping point at this juncture. But just a few examples, because we don't have time, but just to make sure everybody is on the same page. So sort of old school, which was not old school in the 90s, but was the use of just the PEX cards as a way to communicate. That requires quite a bit of motor planning, though, right? To take the card off the Velcro and give it to someone. So the alternative when tablets started out was the Dynavox, which was, I think, at least $2,000 to get, and it was heavy and bulky. Now it's smaller and more compact, but it's still a Dynavox, which is not something people often can buy somewhere. But now we have them on our iPads, and there is just an enormous amount of software that you can get on iPads or other cheaper tablets as a way to doing this sort of augmentative communication that's visually based. But I'm not going to promote any, but I can talk to you individually about some of the more frequently used software for that. And then even newer than that are tablets that don't require you to even do swooshing or pointing, but that can use even just eye tracking just on their own without having to touch the device. And you can see an example here that these are starting to get marketed and out there, but again, require very sophisticated training to be able to use. And we know that it needs to start not just with communicating long sentences like "I want to go outside," but a lot of training and just being able to localize what you want. Again, whether it's pointing or an eye contact. And now we're getting savvier with developing games that are more highly motivating to use, just to get the idea that either putting my eyes there or putting my finger there are going to get us something before getting more complicated with multiple words or multiple choices that are going to be used. And then last is the social communication, which again can be what we're talking about for augmentative communication as well, but just thinking about it specifically here in terms of either using your communication towards someone, just very basically either to request something or to share enjoyment, have joint attention, engage in more purely social behavior. And again, we do have a developmental milestone chart, you could say, for at least just the gestures that we use for social communication. And we certainly know a lot about the deficits in social communication for autism. Is that 1 minute? And so here we're talking specifically about the nonverbal social communication piece of autism, which is not the only symptom, but certainly a really important one. And I think that the take-home point here is that we do have measures that we all know and use to observe these behaviors and look specifically at the deficits in the communicative behaviors used in social situations, like the ADOS. But what we know here, and we've just talked about the intersection between intellectual disability and autism and Phelan-McDermid syndrome, is we know that these autism symptoms are highly prevalent. I think the thing that we need to think about, and that I'll end with, is that the intellectual disability severity that we're talking about here, although there is variability, we really need to think about these symptoms in the context of the global developmental delay, is that a criteria for autism is that the disturbances are not better explained by the intellectual disability or the global developmental delay. So one thing that we need to do when we're using the measures like the ADOS is make sure that we're putting them into context of the global developmental delay itself, that the social communication delays are related to those developmental delays, and making sure that we can separate those things. And with that, with just a few ways that we plan to do this are the genetics first approach that we all know about and are here because of. But we also need to do more research on the full range of cognitive and verbal status just in individuals who are referred for a diagnosis of autism, regardless of genetics. And then we also clearly need better tools for this. And some are in development, like an adapted ADOS, which is for individuals who are older, yet are not verbal yet, but may not be using the same exact toys that you use for infancy, for instance, and even including some other technology like an iPad or an iPhone as something that you would use within the measure itself. And I'm happy to talk with others later, because I think we probably need, again, to do more about augmentative and alternative communication than just mention these few things here. And there's a variety of resources that I'm happy to talk to people about and get more of, because we always need more. And with that, I think we'll move to the next phase.
Okay. Audrey, Dr. Thurm, thank you very much for your discussion, for your presentation, and for getting us communicating about communicating. And I think we're going to start with a poll. Julie, you ready? It's up. Okay. Y'all can vote on poll everywhere.
Hi, everyone. Could I have your attention just for a moment? We've been receiving some comments that some of you were concerned that your questions weren't being addressed, specifically as you're sending them. I want to let you know that we are receiving them. Matt and I are receiving them, and we are passing them on to the panelists. The panelists are doing the best that they can to address them, either through their prepared talk or, or by altering their talk. But given the limited amount of time, we're not able to specifically address everything, but I want to let you know that everything is being recorded, and whether you're sending it to Matt and I, or your table facilitator is recording it, and it will all be included and sent to a researcher and included in the white paper, which will be an outcome of what we're doing here. So please, keep sending your questions and know that they're being recorded and will be addressed. Even if they're not addressed right here immediately, they are being taken by the researchers and will be included in the research paper. So thank you.
Thank you. It's a great pleasure to introduce this panel on speech and communication. So the members of this panel are Dr. Audrey Thurm, who's given a great talk about this topic, Dr. Lara Soria, whose work has been quite rightly cited in many of the presentations and who participated in the previous panel discussion, and Dr. Alex Collefson, who will be also presenting on, I think, the transition across the lifespan tomorrow. Okay, maybe I start with putting to the panel one of the questions that came from somebody who's connected to us via webinar, and that sort of echoes some of the discussion that we had on our table, as well as some of the points that were made in the genetics talk earlier today. And this is the question: how come that somebody who has a small deletion has severe problems with speech and language, and then somebody with a large deletion can speak in whatever, like whole sentences and so on. And in a way that sort of like links up with this whole discussion on superheroes and protective factors, or other factors that might impact developmental outcome other than the sort of main sort of deletion itself. But I'd like to hear what other people on the panel think about it.
I was told that's for me. So this is a great question, and the answer, of course, is that we don't know. I mean, that's simple as that. I think we see kids who have tiny little deletions, who are tiny, even point mutations, where only the SHANK3 gene's affected, and those are kids with severe language delays. And then we see kids with humongous, greater than 9 megamase deletions who could potentially be verbally fluent. And it's very confusing. I think a couple of key issues. One, it is clear that the SHANK3 gene alone is adequate, or the loss of the SHANK3 gene is adequate to produce language delays. And I think also there are other genes all across the genome and probably within the region also that can have an impact on language. So the answer to the question is still, I don't know. But this is something that we're looking at. One of the big goals of the RDCRN that you've been hearing about is to do sequencing across the entire genome and to try to figure out, are there other regions that either compensate or contribute in a negative way to the phenotype and to the severity.
Great, thank you very much.
Thank you for not answering the question. Unless somebody else has an answer to it. I mean, maybe. Okay.
Would somebody else like to answer or not answer this question? Okay, I was very struck by the outcome of the first survey, and that was about whether your children would communicate other than verbally. And let me just check. Well, I haven't written it down, but something like 95% of responses said yes. Is that right? Something in that region, and 5% were saying no. And I was really struck by that, because I think if that question were put to parents with, for want of a better term, idiopathic autism, I think we would have seen a very, very different outcome. And I think that reminds us that there is still a lot for us to be discovered in terms of where are similarities between Phelan-McDermid syndrome, or some people with Phelan-McDermid syndrome, and other forms of autism. Would someone else like to speak to that?
I think just to add to Audrey's point and your point, that the thinking about alternative communication strategies and the diversity of what we see in the Phelan-McDermid population is something that I think needs a lot of attention. At our table alone, we had children that were communicating with Dynabox, with the iPad, with the signs, and right now we don't have enough information about how the genetic information can inform that type of intervention planning. Maybe someday we can get there, but in the meantime, paying attention to how to make professionals comfortable with these tools and making treatment plans related to alternative communication, I think, is a good goal.
Some folks that I've worked with, I've asked to, and they have been kind enough to fill out a form that I'm working on developing for really, really, really subtle ways of communicating. As I mentioned, things just like glancing, looking, moving your arm, things like that. I think we need to pull a lot more from literature and work from some other disorders, especially those with more of a motor component. So I've talked to some people from the cerebral palsy field who are working on alternative ways of testing individuals. Again, it's not going to be one size fits all. So maybe using eye gaze for some and pointing for others. But that the more we can do to sort of train people, then we can start to test and see what people are understanding better using these alternative ways. And just the Rett disorder group is doing a lot of work in alternative ways as well. But it may be with Phelan-McDermid syndrome that there's so much variability even in the motor piece that we're going to have to be much more sort of pick and choose rather than one method for these alternative ways.
Yeah, and indeed, one question was particularly for you was whether you'd be happy to share your top 3 recommendations for speech
So
programs.
was that for software? 'Cause- well, I think it's on the list from the resources on my slide, but I'm not going to mention a few. But I will say Proloquo is very, very popular as software used on the iPad. But I think just like we're talking about for everything else, I think part of why it's popular is because it is really able to be adapted. But you need to Google and figure out, and there's directions for how to do this, because it starts with like 16 or 24, some crazy number of pictures that are used and that you're supposed to do sentences. It's having someone who can really work with it and adapt it and bring it down to whatever level it needs to be brought down to. And it can just be one picture for a long time for a child. That's way more important than the actual software itself. And I think Proloquo is so popular because, well, you can pay different prices for it, but also because it is more easily adapted than the others.
Great. Yeah.
So one thing that comes up a lot is often you'll hear people make very strong recommendations about what to do and what not to do. And so one of the things that I've heard from the community about what not to do is do not use an augmentative or alternative device. And I don't think that we would feel comfortable with that. So if you're being told that, I would probably disregard it, frankly. And this came up at our table also, right? Some people get prompt, some people get AACs, some people get all kinds of different types of interventions. And because we don't know what is going to work, and because there are going to be different sizes that fit different kids, I think you actually have to try a lot of different things, frankly, and see what your kid actually engages in, and what produces anything that's meaningful. And the idea, by the way, behind not using an AAC is that it's going to prevent them from learning language, right? That they're just going to be overly reliant on that AAC. And that's dogma that may be relevant for some kids, but certainly hasn't been our experience. What's that? It's not what the data shows for any population, according to Latha, who knows a lot more about this than I do.
Are there any other questions that came up on one of your tables that you'd like to share?
I had one more that I hear all the time. So the question of frequency, what's the best, or what's the ideal amount of intervention we should get? And I guess we're talking about communication. So often you're offered like a package, right? Here's, and I just mentioned this at our table, here's 2 hours a week of speech therapy. That's what the Board of Ed is going to approve. And we would probably argue that you should fight for more, but if you're going to only get 2 hours a week of speech therapy, what I've been hearing a lot from families is that kids' attention spans are not fantastic, and that it might be better to do 4 sessions over a half an hour than 2-hour sessions twice a week. The idea of repetition, the issues with learning that these kids have, the goal of trying to generalize outside of the session may be better served by more frequency and even less duration. 15 minutes twice a day, 4 days a week. I mean, these are all things to be thinking about. Again, we don't know what the ideal prescription is, but I think the idea of sort of increased frequency and more intervention.
Yeah, I'll just echo what you're saying about people saying no, don't do this, or stopping. Just empowering you all as the parents who know your child better than anybody and can see what they may or may not be able to do. Just encouraging you to speak up with, when you're just handed a device and said, here, use this, it's not going to work. And so you can say, I need to know what to do with this. I need help. And just letting them know what you do know about your child, and how they can communicate. The first thing after I just gave my talk is someone said, thank you. I thought I was crazy because I really did think my child was communicating when he's doing X, Y, Z. Well, they are. If you think they are and there's meaning to it and you give something and they're happier, then that is communication. And that's what you should just do your best to communicate to the speech pathologist to help move things along.
Thank you. Any other questions from your table?
few about just the challenges with knowing what your child knows. So we've been talking about expressive, sort of communicating needs and functional needs, but how to assess what your child knows and the sense that they know a lot more than they can express. And I just wanted to raise it because it is, I don't think there's a good answer. But if anybody else had ideas about how to get at receptive communication and knowledge in a way that is helpful. And is it the way we're presenting the information? Are there just ways we can think about improving, tapping into what their knowledge base is? And is it through other modalities?
So on our table came up one person sharing the experience of his son being great at language, but maybe struggling with other issues, maybe attention or some other aspects of cognition. And I think it made me sort of think that maybe we need to, really compile quite a comprehensive profile of all the cognitive or psychological and social strengths and weaknesses for each person to have a better chance to predict what they need and how they will develop in the future, than if we only concentrated on one domain in and of itself. Because in this particular case, it would suggest maybe that if we only focused on language, we might overestimate an outcome, whereas maybe some other potential skills might go undetected because the young boy in that case might not be willing or cannot be so easily drawn into doing something that could help his improvement. So I think I'd be really interested to hear from all of you, for those who are interested in having more of a broader picture of all sorts of like anecdotal information about both sort of strengths and weaknesses, and also the likes and dislikes, and to see whether we can perhaps in our future research incorporate some of the likes in order to make it easier for children to participate in research. So for example, if somebody likes playing with iPads, that might give us maybe a possibility to develop tasks that tap things like whatever memory or attention or so, that helps the child to be at least to an extent engaged in doing that kind of work. Maybe that might be optimistic, I don't know.
One of the tables asked, can we have that comment about frequency of speech therapy and writing? And I think there really is a true, I think that was a little bit of a half-joking question, but I think there is a real need for the development of some guidelines and practice parameters for speech. So I guess, when is that coming?
We can definitely put in writing that things need to be individualized for the child's strengths and weaknesses. And I know that sounds generic, but we can get a little bit more specific about that. But it's true, because we don't have enough information to say that every child, it should be 4 times a week for 15 minutes, but that you can't just, that's all you were saying, you cannot just prescribe one thing, that it really has to be individualized. And often that's not going to be known until you try something. You might have an assessment phase with any therapy that you start before you can really figure it out.
Just to add, I think that question though points to something we hear a lot, is that the idea that practitioners are not comfortable, whether it's educators or speech therapists or physicians, not comfortable when they hear about a rare genetic disorder like Phelan-McDermid. And ideas for what we can do to make them comfortable, like these practice parameters. And just to sort of throw it out there, because I know Autism Speaks is here and invested in some of the, maybe not, but knows about this, is there are physician and practitioner training models, like telehealth training models, that could be ones that we think about in rare diseases like Phelan-McDermid, and thinking about the ECHO model for making people more comfortable with the individualization that's needed and not needing to quote Alex for everything.
Good point. Let's check whether there are any other questions from the floor. Yes?
Reasonable length of time when you're in type of communication structure for your child to give it a chance to work, because one of my great frustrations with schooling is, well, we did this for 2 weeks and he threw the device on the floor, so obviously he doesn't want to do it. And you know, Jake is 22 now. Finally, when he was 14, I said, enough of this. We need to find a communication strategy for him that's going to work. I don't care what it is, but we can't be changing it every month because you decided it didn't work. You know, it's like they'll try one device, they tried PACS, they try something else, and it was just a merry-go-round of things.
So we could take all the scientists in this room and ask them that question, and you'd get a different answer from each and every one of them. I mean, we could throw out numbers, and it's just clinical impression, and it's based on our experience talking to families. I can throw out my number, but it's not based on any actual evidence. You ready? 3 months.
Huh? Oh, as a behavior analyst, I wouldn't give a number. I would say if they've tested motivation, and so they've tested it in the right way, right? They've gone through and they said it's not just it's the way they learn, it's the tool, the types of stimuli that they like to learn with, and you're rewarding them in the way they'd like to learn, and you've gone through that with the system, and it still doesn't work, then you would move on. And it's a clinical judgment at that point rather than a time.
I'll just add a few factors. Motivation is the number one factor. So again, I don't care what the curriculum says, but you know, if he just likes to ride in cars, then a picture of a car, but he has to make that connection or whatever, bananas, iPad, whatever it is, it has to be the most motivating thing to start with, or else it's not going to work, whatever that is. But the other factors that go in is, you know, is he breaking an iPad every day? Is he hurting people? You know, what are the negative consequences of continuing to try? And really, you know, did they start with 16 pictures when he needs one? You know, are they doing it the right way? So it's not a matter of time. It's a matter of putting all these factors together and saying, if we, you know, systematically change this, does that improve it a little bit? If we systematically change this, does that improve it a little bit? So it may be, you know, 1 day or 1 minute, depending on how negative the reaction is, and then making sure that it might not have to be a huge change, but some change to be increasing the output. He likes my answer better.
Okay, great, thank you. We've reached the end of our session. Many thanks to all the members of this panel. Many thanks to you,